Hello and welcome to Yashoda Hospitals. I'm Pratyusha Chaudhary, hosting Nursing Education and Training webinar series live on Facebook every Thursday at 3 p.m., bringing forth the most interesting topics for you. So we thank you for joining us today, and please stay tuned till the end so that we can dive deeper the discussions with our expert panelists. Let us talk more about it through our topics. So whenever we talk about the critical care areas, we require the nursing expertise. And to talk about the core skills required, it cannot be defined in one simple term. Hence, there is a small mnemonic and a structured format which we can follow in every day of our day-to-day life in the critical care areas. That's nothing but fast HUGS bit. So it made our life easy. But still, talking about the benefits of it, core values of it, what each component talks about, and how we have to evaluate and assess each criteria, let us dive deeper into the topic, more into the terms, and talk with our speaker, also with our expert panelist. So I take the privilege of welcoming our expert panelist for the day, Dr. Kalada sir, who is a senior consultant and HOD critical care medicine, who is the backbone for nursing education and training, and he is well known for the support for the nursing education throughout Malakpet. We welcome you, sir, for joining us today, and looking forward for your insight and for the more informative session for today's webinar.
Thank you.
And I'm happy to welcome our speaker for the day, Ms. Bhulakshmi, who is young and dynamic always, and she is a DGM nursing at Yashoda Hospitals, Secunderabad. So who holds a vast clinical expertise. She is going to talk about fast HUGS bits and the essential care aspects more deeper, and where she will talk more detailedly in each component. So let us not wait for the delay, and let us start the session. So stay tuned till the end, and please do drop your questions or queries whenever we are trying to take out the session. So at the end of the session, we are going to take your questions and we'll try to discuss about it. So over to you, Bhulakshmi.
Thank you, Pratyusha. So, good afternoon to one and all. So the today's topic is about fast HUGS bits, which is a very specific agent or a specific checklist which will be used in our critical care, so on a daily basis. So today we are going to see about the objectives, which will be describing the components of fast HUGS bit, and as well as the checklist which will be used on a day-to-day basis in the ICU to make our work more easy in the critical care units. So why the fast HUGS bit is more important for us, and why do we need it in our day-to-day life is this is a checklist which is basically speaks about the significant aspects in the general care of the patients which are in critical care. And it also improves the quality of patient care, and it increases the safety and efficacy of the patient care. And it also involves a multidisciplinary team, and it helps in preparation for the patient rounds, and it also helps to prevent and identify any medication errors and promotes the patient safety. So what is fast HUGS bit? So the fast HUGS bits is elaboratively called as the fast is meant for, F is for feeding, analgesia, and S stands for sedation, and T stands for thromboprophylaxis, H stands for heads up position, and U stands for ulcer prophylaxis, G stands for glycemic control, S stands for spontaneous breathing trial, and B stands for bowel care, I indwelling catheter removal, and D is for drug de-escalation. So let's go in detail about one by one. So the F, if we take it F, the feeding. So the feeding is more important in the critical care setting because the patient cannot express his hunger. So if we are not taking care of the feeding parameters in the initial 24 to 48 hours, the patient can go to the malnutrition, which can lead to a lot of effect on the patient health condition. So which the malnutrition can also lead to increased susceptibility to infection, and there might be poor wound healing and loss of muscle mass, and there will be bacterial overgrowth in the GI tract, and in turn related to, in turn it will impact on the ICU stay, and as well as hospital length of stay can be increased. So what is the need for that? Nutrition is to meet the nutritive demands of the patients in the ICU. And what is the main nursing role in terms of feeding for the ICU patients? There are two methods of feedings which we'll be using in the ICU setup: the enteral feedings and the parenteral feedings. The enteral feeding is like nasogastric or orogastric tubes, which we will be starts within 24 to 48 hours of the patient stabilization in the ICU setups. And the parenteral will start with TPN. So if the patient is not able to take in the enteral route more than 7 days, then we automatically turn on the patient to the parenteral route. So we have to start with the nutritional assessment. We have to check the height, weight, BMI status, and the malnutrition condition of the patient. We have to do the nutritional assessment, and we have to check for any symptoms of gut dysfunction and the intolerance of the patient. So the gut dysfunction, like patient can express the symptoms of like nausea, vomiting, and regurgitation, aspirations. And the intolerance can be because of medication usage, antibiotics and all. So how are we going to improve the tolerance of the patient is like use of prokinetics, and then head of the bed has to be elevated 30 to 45 degree angle all the time whenever we are giving the feeding. And we have to aspirate and see whether the pre-feeding, the before feeding is being digested or not. The aspiration has to be there, and the flush the tube after each feed so that no occlusions will be there in the tube. So the recommended calorie intake for the patient is 25 to 30 kilocalorie per kg per day, and the protein will be 1.2 to 2 gram per body weight is the reasonable target intake which we will be aiming for the ICU patients. So coming to the next parameter in the fast speed is for analgesia. So which plays a more important role because we have to reduce the pain to the patient, because he will be, because of illness and because of the tubes, lot of tubes, CT tubes and tracheostomy, Ryle's tube and suctionings, the patient will be in huge pain. So we have to reduce the pain. So the need for analgesia is like we will be optimizing the patient comfort, and it will also in turn we can reduce the stress response to the patient. If the patient is under the stress with the pain, it will automatically increase the metabolism, and it increases that the demand will be more on oxygen consumption. So we have to reduce on that, and so that the stress response can be calmed down. So the pain always we will be assessed with regularly with the VAS scale. If the patient is on conscious state, we'll be going with the numerical pain scale, and if not, then we will be going for facial expressions. We can evaluate the pain score of the patient. So if there is 0, then we can consider it as no pain, and 1 to 3 it will be on mild pain, and 4 to 6 is on moderate pain, and 7 to 10 can be the severe pain. So according to WHO, there is a pain analgesic ladder which will be using it. So if there is a mild pain, we go with administration of non-opioid analgesics. The examples of non-opioid analgesics can be aspirin, paracetamol, and NSAIDs. Without adjuvant analgesics, we can add the adjuvant analgesics can be antidepressants and anticonvulsants and topical anesthetics and all, etc. So when the patient is having a moderate pain, we can go with weak opioids. So the weak opioids example can be tramadol and codeine. So we can add on with the non-opioid analgesics or adjuvant analgesics. If the patient is having a severe pain, then we have to go with strong opioids, which are like morphine and fentanyl, which is the drug of choice, which we are using is of fentanyl. So this is the pain analgesic ladder as per WHO, which we are following it currently in our ICUs as well. So then coming to the sedation part. So the sedation part will be like the main issues why we have to concentrate on sedation is also the both parameters are very dangerous to the patient. The over sedating and under sedating the patient is both are too complicated to the patient. So hence we have to be more careful while giving the sedation to the patient as well. So the adverse effect of over sedating can result in respiratory depression and hypotension, and there can be prolonged ventilation and risk of ventilator associated events, and as well as we will be risking of the patient, and we are unnecessarily usage of resources also can happen because of this sedative utilization. And the next one, what is the need why we have to sedate a patient is for and especially to control agitation to enable the effective care. So if we control the patient agitation, and then we can give effective care to the patient, and we can control intracranial pressure and reduce metabolic rate. And we can also prevent accidental extubations or removal of vascular access catheters, because there is a patient tendency, because of the irritation and because of the pain, patient tend to remove the tubes, and patient will try to remove it. So we go for the sedation option for that. And what is our nurse's role in that is adequate depth of sedation. See, the sedation cannot be overloaded and cannot be undersedated the patient. So always the adequate depth of sedation has to be given with calm, comfortable, and collaborative level. So we have to evaluate the depth of sedation by GCS or RASPO. So the GCS, as all of you know, that is the Glasgow-Coma scale, which we will be evaluating the patient for eye opening and verbal response and motor responses. And the RAS score is for Richmond Agitation Sedation Scale, which we will be using to check the patient agitation and sedation levels. So this is a score which we will be using it through observation and through responses, verbal response, and as well as to the stimuli. We will be checking the patient response on these parameters. So coming to the next parameter in the FAST is thromboprophylaxis. So when the patient is on ICU, the most important factor which we will see, patient will be confined to the bed, and which can also lead to thromboembolism. So the nurse should act fast enough. Within 24 hours following the admission, the nurse should go for patient mobilization, and we have to prevent deep vein thrombosis or pulmonary embolism to the patient. So the VT, venous thromboembolism, can happen, hypercoagulability, and then vascular damage can happen, and circulatory stasis can happen to the patient. So hence, the fast acting of thromboprophylaxis measures can save the patient life. So the methods which we will be using as a prophylaxis are like mechanical methods and early mobilization and the pharmacologic agents. So coming to the mechanical, graduated compression stockings, and then intermittent pneumatic compression devices and sequential compression devices, which we are using currently is SEDs, which we are following everywhere. And the pharmacological agents are, we can go with low-dose heparins and the low molecular weight heparins, like 5,000 international units, subcutaneous we can give, and enoxaparin or dalteparin or tinzaparin that can be administered as an anticoagulant. So the next parameter which we will be using is in the FAST is done. Now coming to HUGS. So in the HUGS stands for, H stands for head up position, which is the most important and then very, very easy step which we can prevent a lot of aspirations to the patient and as well as ventilator associated events to the patient by the simple technique that is head up position. So we have to elevate the head of the bed to 30 to 45 degrees angle, which will reduce the gastrointestinal reflex and as well as aspirations and as well as ventilator associated events. So the next part is of ulcer prophylaxis. So the main why the patient can develop the ulcer is of because of the stress, because of the illness, the patient mucosal damage can happen, and as well as obviously it might lead to sometimes the bleeding, the gastrointestinal bleeding can happen to the patient. So what is the criteria where we go for ulcer prophylaxis is when the patient, the minor criteria which we use it like sepsis, and if the patient is more than 1 week in the ICUs, and if there is any occult GI bleed for more than 6 or more days, and the glucocorticosteroid therapy if you are using, and the major criteria like if the patient is on mechanical ventilator for more than 48 hours and there is a prior ulcer to the patient, the prior history of ulcer, and coagulopathy, if you can check platelets less than 50,000 and then INR more than 1.5 and PTT is more than 2 minutes, then we have to definitely go for ulcer prophylaxis to the patients. And how are we going to prevent the ulcers is like we can only prevent the stress ulcers in the ICU patients with H2 receptor antagonist, which is ofranitidine, and proton pump inhibitors like omeprazole or rabeprazole and pantoprazole injections can be given, and antacids and sucralfate is the best choice for us to prevent ulcers. So that is what about the ulcer prophylaxis. And the next G stands for glycemic control, which obviously is a major role to prevent mortality and length of stay and infection in ICU patients. So both hyperglycemia and hypoglycemia can impact the patient condition. So glycemic control is more important factor for us, or else which will be having a decreased wound healing and increased infection risk and increased risk of polyneuropathy. So what is our nurse's role is like, obviously what we are doing on is as per the doctor prescription, we have to go and check the GRBS as and when required, and we have to go for the pharmacologic glucose control. Either we can give human actrapid or mixed rate, whatever is being prescribed as per the doctor prescription, we have to go and check on it. And we have to check the hypoglycemic status of the patient. When the patient is on a venti and mechanical ventilation, or on not conscious state where he can express his symptoms, we have to check his SpO2 levels, and we have to check on that part whether the patient is going for hypoglycemia or not. And the next S stands for in the HUGS is spontaneous breathing trial. So how are you going to check on the spontaneous breathing trial is weaning of the venti and weaning of the sedation is most important factor for us to prevent the VTEs and all. So 30 minutes of weaning is more important for us to check on the patient improving status. So for that, our nurse's role is whenever we are weaning off the patient, or whenever we are pausing the patient on for 30 minutes, we have to always check the saturation levels and support him with the external oxygen support with mask or the nasal prongs, and always check for the saturation levels. So the weaning methods for spontaneous breathing trial can be like, we can skip on to the mode to CPAP mode we can keep, and we can go for TPs modes. So those methods we can utilize for using the spontaneous breathing trial to check the spontaneous breathing trial of the patient. So the next can be like bowel care. So which is also, now we are coming to big parameter. So the bowel care is most important, like the patient mostly in the critical cares can have two effects, whether the patient can have diarrhea or patient can go for constipation. So the diarrhea, most likely it will impact on the patient, electrolyte imbalances can happen, and dehydration and hemorrhoidal irritation can happen, which will be resulting in anemia and delirium to the patient. And when it comes to the constipation, patient will have a lot of discomfort, and feeding intolerances can happen because of that, and delirium also will be the resulting factor of the constipation. So how are we going to take care of that patient is like, we have to appropriate bowel function has to be checked, and then bowel care regimen has to be planned for the patient. As a nurses, we have to check and observe the abdomen for any distension, and check, auscultate for bowel sounds, whether it is increased bowel sounds or high-pitched bowel sounds or decreased bowel sounds, that we can check, or whether there is absence of bowel sounds, that also we can auscultate on that part, and palpate for any tenderness, tightness and rigidity. And we can document in our intake and output chart whether the patient has passed the stools, and then our urine output, and what is the passing of the flatus. So that can be checked on that, and then it can be immediately reported to the consultant on that basis. So the next parameter is indwelling catheter removal. So the major factor here which we have to consider is potty and clepsy, catheter-associated urinary tract infections, and central line associated bloodstream infections. If we are not taking care of our catheters, so both the things can happen. So we have to remove Foley's catheter, PICC lines, and any central venous lines, arterial lines, epidurals as soon as possible. As per the doctor prescription, we have to remove. And or else if it has to be continued, then we can change as per our period of changing time. As per our policy, we can change the lines, either Foley's catheter or Ryle's tube are the central lines, and then peripheral lines. So our nurse's role is most importantly, we have to check for the insertion site, we have to check for any signs of infection like redness or warmness or any kind of oozing is happening on that. And then tubes and catheter care can be given to prevent potty and clepsy on that part. So the last parameter is drug de-escalation. So most likely the antibiotic usage can be more, so have to be de-escalate on the drugs to prevent the resistance, the drug resistance to the patient. So de-escalation is more important, like the doctor can prescribe from broad spectrum to narrow spectrum antibiotics so that the single drug can be used for the patient, and also the overload of antibiotics usage can be stopped. And what is our nurses' role is we have to watch out for any discontinuation of antibiotics or any change in the spectrum of antibiotics from multi-dose to the single dose. So that also has to be checked, where we can prevent the drug resistance to the patient. So this is for it's like complete of fast HUGS speed. So what is the nurse's more important and crucial role is to promote a quality care. Every day you have to give your patient with fast HUG. So the fast HUG is more important to improve the patient safety and as well as to improve the teamwork of in the critical care units. So any questions for these fast HUG bits, you can impose on that.
Thank you, Bhulakshmi, for the elaborative and simplified session on fast HUG bits. That was a very impressive and informative one. And the panel is now open for all the audience. Like, please do chat us and just post whatever you have the queries to talk about the fast HUG bits and the critical care areas, so that we can talk about those and then we can solve your queries. So before taking the questions, sir, can you say, like, or you support this fast HUG bits as a point? Like, is it a structured one, the mnemonic which we follow in all the critical care areas? Do you say that this is a structured one, this can be followed in all the critical cares?
Yeah, thank you, Bhulakshmi. Actually, that was a very elaborated and very good presentation, nice presentation. I think you elaborated each of component of FastHUGS BID in a very good way. So I think it's very understandable to even junior nurses and all. And as Pratyusha is asking, it is very important, and it's like a protocol. So it's like you know the protocols and checklists. As you look at the aviation industry, where they check everything before any plane takes off, which makes the safety the utmost point. The same thing has to be applied to the intensive care unit patients, wherein so many complex things will be involved at any point of time. Suppose I will give you an example and we will go through according to that. Suppose at the end of the presentation, as Bhulakshmi mentioned, this FastHUGS BID should be given every day. It's a continuum of care, not at one point of time, maybe a continuum of care, because the ICU patients are very complex, and the internal dynamics and the patient dynamics do change. Depending upon that, maybe we have to implement your FastHUGS BID. For example, I will tell you one of my patient right now there in ICU. She's a 21-year-old. She's a diabetic type 1. So she was using insulin for the diabetes control. She developed a fever and she developed acute gastroenteritis. So it was gastroenteritis. Then she landed up in severe breathlessness. When she came to ER, actually the BP was almost non-recordable, and the patient was GCS dropped down to below 8. So we had to intubate tachycardic and hypotensive. We had to intubate that patient because of drowsiness. Found out to have the ABG of pH of around 6.8, very severely acidotic. Then checked the urine ketones, which are large. Slowly our AK, she landed up in dehydration, leaded to acute kidney injury. So in this patient, we initially, anyway, because of acute GE and fever, we sent blood cultures also. So what are the day first? And there were tests like the platelets on the borderline 1 lakh, and the INR was 2, around 2 and all. So at this point of time on the first day, what do you generally the FastHUG BD, what do you apply? Suppose from the aspect of feeding, if you look at she presented with acute GE, you may not be going immediately start feeding this patient, because already she's suffering with acute GE, with the feeding will further exacerbate. You may have to wait to give some ball at some point of time. Analgesia, yeah, sure. Probably because she might be suffering, even though the patient is having low GCS, they may be suffering with the analgesia. So you have to give the analgesia. But sedation, yeah, the patient already came in drowsy state. Maybe during intubation, you need sedation, but later you have to look at what is happening. These patients who are having PK are prone to develop cerebral edema also sometimes. We do see CT brain was normal in this patient, but yeah, we have to taper the sedation as she was telling according to the Richmond agitation scale. So, and then thromboprophylaxis. Do you recommend thromboprophylaxis in this patient?
Yes.
Already bleeding is there.
Because the platelet counts are borderline and there is INR
Again, there is a
elevated.
chance of bleeding.
And, yeah, chances of getting bleeding will be there. You will not be giving a thromboprophylaxis. And added elevation, of course, most of the patients who are ventilated, so they have to be elevated, because the added elevation in across different studies have shown that if it is more than 30 degrees, the possibility of aspiration and the aspiration pneumonia can be prevented. Some studies were disfavoring that, some studies, but overall it looks like it's better to follow head and elevation, especially in patients like the ventilated patients. And even if there is any increased ICP patients, something like head injury patients, head and elevation makes them, because if you do head and elevation, the ICP, it's like ICP reducing maneuver. So it will be helping them. So ulcer prophylaxis, of course, most of the patients are at risk of developing stress ulcers, something called curling ulcers. So in those patients, yeah, most of them, they require the ulcer prophylaxis, especially what we use routinely is proton pump inhibitors, something like pantoprazole. So ulcer prophylaxis has to be given. And glycemic control. If you look at this patient, the glycemic control is very important, because she is the one who presented with diabetic ketosis. Sugars were initially more than 600. So you have to pay attention to our glucose control, especially these subset of patients. But you will not be aggressively decreasing the blood sugar control. Actually, in ICU setups, the sugar control, the sugar targets will be between 140 to 180.
Yes.
So previously, when Vandenberg et al. Study demonstrated where strict glycemic control has to be followed, which improves outcomes, later it was more hypoglycemic episodes were found in other further studies, and nice sugar study came in. Then they targeted, I think it's better to target between 140 to 180 rather than strict glycemic control where the sugars will be going down below 110. And the patients are prone at risk of developing hypoglycemic episodes.
Yes.
So this is the reason you have to have the target of 140 to 180, but it may vary. Suppose this patient presented with 600 blood sugars, he may not be making that patient sugars to come down drastically to 180, which may be counterproductive, further exacerbating probability of any cerebral edema and all. So the target will change in this patient. You will be gradually coming down. So that is where it also differs. So other things, yeah, bowel care and indwelling catheter. Yeah, this patient was having AK, then we had to put her a femoral sheath, a bit of hypotension was there. We had to put in arterial line and a central line. So these indwelling catheters have to be looked after. If she is taking much time, 5 days, 7 days, periods of time, it has to come out as early as possible. So looking at these catheters, what is happening. And at the same time, the other things like de-escalation of antibiotics. This patient presented with acute gastroenteritis. Because she was hypotensive, we started with broad spectrum antibiotic, carbapenems. After 72 hours of the blood culture grown E. coli in this patient. But it is susceptible to ceftazidime and sulbactam. That is where the de-escalation of the antibiotic is very important. Suppose this patient initially, anyway, you started carbapenem, but it is susceptible to ceftazidime and sulbactam. So you have to de-escalate the antibiotic, change to ceftazidime and sulbactam. That is where the de-escalation of your drugs, especially antibiotics, is very important. So this case illustrates these components like every day. Suppose once the patient after 3rd days, the sepsis component got better, and our platelets are improving and INR got better. Initially, maybe there was some moderate DIC. In this patient, what happens? You have to consider thromboprophylaxis, especially the patients who are having PK. They are at risk of developing prothrombotic state and all, at risk of developing the thromboembolism also. Then maybe after 2-3 days, if you are still, the patient is still not coming out of the ventilator, and the patient is not much mobile, probably once the coagulation parameters gets better, then you have to consider the DVT prophylaxis. So as a whole, you have to think, and then probably, yeah, one patient having so many things, this is a complex environment, ICU. And the protocol should be, this protocol, especially fast track BID, is very much useful because it delivers the basic important care to the patient, almost as a whole. So that is
as you said, like it is comprehensive. There is few things that we have to tailor according to the patient's need.
correct.
So like everything cannot be applicable, but we have to make sure either the patient is at risk or the patient requires some kind of intervention already, which the patient has developed.
Yes.
So in case, if we talk about feeding, there's one controversial issue every time that comes into our mind, like, do we need to aspirate the content and should we discard it, or should we again redo it into the same line?
Yeah, the thing is basically checking gastric residual volume. So it has put to a lot of debates. Like the most of the guidelines, if you look at the Enteroparental Society guidelines, even your ASPEN or SPEN, American Society guidelines or your European Society guidelines, they recommend generally whenever there is a gastric residual volume, you will be checking every 8-hour shift. If the gastric residual volume is more than 500, then only you will not be feeding the patient if you are okay to feed the patient in that scenario. But if the gastric residual 500, don't stop feeding, you have to continue the feeding. But probably you have to, maybe if it is supposed 250 to 500. 500 doesn't mean that if the patient is for 450, it is still a bit high gastric residual volume. In those patients, you give prokinetics and feed them. And another thing is, most of the times you think that you gastric residual volume, you aspirate, and generally the recommendation is, if it is more, suppose more than 300 ml or 400 ml, it should be returned back to the patient because there may be electrolyte disturbances involved because you are aspirating gastric fluid. There will be loss of your chloride, it will lead to metabolic alkalosis, loss of H+ ion. So these things will be there. So because of, but what happens in general your routine practice, whatever you aspirate is you aspirate with from the 50 ml syringe, but you have to keep a good sterile bowl besides you, aspirate, and with 50 ml syringe, probably you put it in your sterile bowl, and if it is more, then actually take from that sterile bowl and give it back. That practice, most of the, in practical scenario, most of the nurses, they don't do. What happens, they aspirate and they put it push it somewhere. Then if it is more, discard somewhere. Then if it is more, then you can't take it back. So probably you expect for every patient to prepare a bowl ready and aspirate and discard into that bowl. And if it is more, probably when you are planning to give it back, you can give it back from that bowl. I think that is a better practice. But yeah, a lot of debates nowadays. The society guidelines are telling not at all need to check for your even gastric residual volume. The regular checking, of course, very important thing. Even bowl sounds may not be giving that much clue. The probability of any worsening abdominal distension, the probability of especially that is most clinical examination. Most of the times, looking at the abdominal distension is the one which will give much of the clue.
So as you said, like how often we can check with the gastric residual volume?
Generally, it is recommended every shift we can check. We have to check every 8-hourly. If the patient, of course, is developing worsening abdominal distension, maybe we have to check if it is more than like maybe frequently, every 4th hourly. Suppose you check around 4th hourly and the gastric residual volume is somewhat 600, 800 ml. Probably you have to, there is a protocol where suppose if it is less than 250 to 500 and more than 500. If it is less than 250, most of the times you continue full feeds. Whatever you started with some 50 ml per hour, you give 50 ml or 75 ml, full feeds you have to give. But if it is between 250 to 500, probably you reduce the feed to around half the feeds. Whatever you are giving of the feeds and give prokinetic, assess after 4 hours. If it is still like if it is not much of GRB, like then gastric residual volume, you can resume to the full feeds. Suppose if it is more than 500 ml, probably stop your feeds for 2 hours, give a prokinetic agent, and again check. So if it is not much, then again you resume feedings with 50% of your target, initial target. Then slowly, according to that, check every 8 hourly, and if it is not more, then resume to the normal feeds.
And talking about the sedation vacation, what is this, and how you wanted a nurse to start doing and understanding the sedation vacation?
Yeah, that is very important. Sedation vacation, yeah, any patient, initially, if you start any patient to be, you ventilate the patient, you will be giving full sedation for maybe 24 to 48 hours initially. So once the underlying cause is getting better, suppose I told you in index case where the diabetic ketoacidosis is leading to hypotension, even there is a very bad acidosis, 6.8 pH, very high sugars, drowsiness. So the underlying cause has to be resolved. Suppose in case the acidosis is very bad, 6.8, it has to be normalized. Whatever the high gap is there, it has to be normalized. The sugar should be controlled. The hypotension should not be much. So that means the BP should be well within coming to normal or minimal vasopressor support. Once the underlying cause is getting better, probably you think of spontaneous breathing trials, spontaneous awakening trials, because your intention of stopping sedation is nothing but you put the patient ventilator. Now you are planning to take out the ventilator. So the underlying cause, once it gets better, of course, you stop the sedation most of the times altogether, starting in the morning hours, early morning hours. Then assess the patient accordingly. Suppose the patient background alcoholic is there, he may be getting irritable. Then switch over to the mild sedating agent. Something initially, generally what we follow is we start with fentanyl and atracurium, these combinations. Suppose you stopped this, the patient is getting very agitated because maybe having a background alcoholic withdrawal. You start with dexmedetomidine, which is a mild sedative, and it will not cause much of respiratory depression, and the patient will be calm and will be cooperative to you. So this can be like in between switching over to a mild sedative. So once you assess, then patient will be awake and he will be spontaneously taking breaths. Then you put them in a spontaneous breathing trial. So switching over from controlled mechanical ventilation to the spontaneous breathing ventilation, nothing but pressure support ventilation, something like that. So you assess them. For generally, for assessment, around 30 minutes of your spontaneous breathing trial is enough. Once 30 minutes, you look at the patient and the patient is tolerating very well, good tidal volumes, not much of respiratory distress, not much of hemodynamic disturbances, the patient is cooperative, then you may have to sometimes go for taking an ABG and look at the gases, or if the patient looks very stable, probably you extubate the patient. But during these 30 minutes, whatever the instability comes, probably again you switch back to the full sedation, probably for some more time and then go back. So most of the protocols nowadays are concentrating towards minimal sedation. Sometimes only sedation without muscle relaxant, up to 24 until unless some exceptional cases where severe ARDS. Of course, severe ARDS, you need proning. Up to that point, you need everything. Like you need muscle relaxant, you need deep sedation. If the lungs are fine, but some other cause is there. Suppose in this patient, the problem is with shock and drowsiness and severe acidosis. So initially, maybe for 24 hours, you may be controlling. Probably after that, just only fentanyl and look at what is the response. So like that, you have to titrate according to the patient condition.
Thank you, sir. What is your take-home message that you want to give for the nurses?
Yeah, the thing is, whatever actually speaking, whatever we theoretically discuss has to be followed practically. That is very important thing. And yeah, be mindful and aware that these protocols, like whatever FASTag is there, you tick it, or otherwise, if it is not applicable, you cross it. So whatever it is, that thing has to be there, put in place. And then if you have doubt, probably discuss with the doctor every day. So I'm thinking this is feeding analgesia, this patient. If you do that now, suddenly the doctors who are busy, sometimes they may be missing the basic thing like thromboprophylaxis. Sometimes because initially, as I told in this patient, suppose the platelets on the lesser side, I would be thinking again it's the thromboprophylaxis, but next day platelets have come to normal, but it might have skipped out of my mind about thinking about thromboprophylaxis. But if the nurses, they look at regularly every day, sir, today platelet counts are normal, probably can we think about thromboprophylaxis? Yeah, that type of initiative, if it comes from the sisters, I think that's going to be very good. Probably, I think every day try to implement this protocol and try to practically apply to the patient. Yeah, because it varies between patient to patient.
Great, sir. Thank you so much, sir. It's a really informative discussion that you have made, and you made it very simple by taking a small scenario and explaining about the fast habits. It's also wonderful taking your inputs, Bhulakshmi. Like, you made the session really wonderful by creating a broken down concepts of fast habits. Thank you so much, both of you.
Thank you, Bhulakshmi.
Thank you, sir. Thank you, Pratyusha.
Thank you so much, everyone. Please stay tuned to us till next Thursday. We'll be coming up with the most interesting topic and a panel discussion about the career enhancements after your BSc nursing. Also, please do share and like us, and please do share this informative nursing webinars onto all of your platforms so that people will be aware about it. Thank you so much. I also am not least but not the I wanted to thank all my best team who is the backbone for making this happen. So firstly, I thank Dr. Pavan sir, who is our director at Yashoda Hospitals, for giving us this opportunity and platform to enhance the nursing education. Also, Amar sir, Lingaya sir, also our Vimla Prasad ma'am, who is our nursing education GM. And wonderfully supporting for all of the webinars, Mr. Pavan, who is the DGM digital team. Thank you so much, everyone, as a team.
Thank you.
Thank you.